Okay, all right. Okay, come on back. I was just told I'm not allowed to tell any inappropriate jokes, so maybe one later, we'll see. Okay, so I'm back. I'm here to give you a talk about pediatric rashes. Now, after this talk, I can't imagine you not feeling itchy and squirmy and wanting to take a shower, so I don't blame you. But the purpose of this talk is to not have you memorize all the things on this slide. I want you to be able to pick out the nuances of certain rashes and how they present, and be able to filter out the rashes that you know are probably going to get better on their own, but be worried about the rashes you know that you see that could be something really bad. So let's start off with something easy. Let's talk about diaper dermatitis. This initially is a chemical dermatitis, typically from urine, dampness, and feces from diapers, right? It can happen in kids, it can happen in adults, it can happen to anyone that wears a diaper, right? So what happens is that you get all of that urine and feces in there, and it's moist, and it's a great environment for there to be an infection later on if it gets worse, and we have some pictures of that, or potentially even a Candida infection, right? So the difference between finding that Candida infection is looking for those satellite lesions. And I have some good pictures of that in the next slide as well. We'll point those out. In which case, you would want to treat for that with meconazole or clotrimazole. And sometimes, like if mom comes in and says, okay, you know, this is the diaper dermatitis rash we have, mom. Okay, we're going to treat that. We want your baby to have a little naked time. Basically wash the baby, soap and water, and let them dry out for a little bit. Now, it's a little more concerning when you have grandma running around having naked time, but it really does help when you just leave that diaper off for a little bit, all right? No shame in that. So if it's really bad, they come back a second time, then sometimes steroids are indicated. So if you look at this top picture on the left, you can see this is sort of a mild diaper dermatitis. Don't really see any satellite lesions there. This make us suspect Candida. But if you look at the one on the right, you can start to see it kind of spreading out. It's red in the middle, spreads out to the sides, and that's when we're concerned about that fungal infection. The bottom picture is a really severe case, very painful for those kids, right? So as Rick already said in his talk, make sure you take off the diaper and take a look down there. Really good treatment is zinc oxide, right? So we like Desitin, we like butt paste. In fact, people of all ages use it. One of my best friends uses it when he rides his bike so he doesn't get chafed. So it has a lot of uses. It's great for kids and anyone else that needs it for a diaper. Let's talk a little bit about scabies. Now this is a mite that burrows into the skin and pees and poops in your skin. That's why it's itchy. So they form these little linear burrows in the web spaces of your fingers, in the creases of your arm, in the groin line, anywhere where basically they can sort of burrow in there and remain hidden, they're gonna stay. And when they first get in there, they're not very itchy. But then, like, just this crazy itchiness. People come in, I can't stop itching. They have scratch marks all over them. They're talking to you and you're kind of scratching because they're scratching, and then it's just like, does that person have scabies? You know, like, I want to see it. I want to make sure, okay. But the way that you tell the difference between scabies and, say, lice, which I'm going to get to in a moment, is that they form those little tracks. And the treatment for this is a little bit complicated. So let me just show you a picture first. Oh, that's what the actual mite looks like there. But you can see in this picture, you see the little bite marks within the web space of the hand in that top left picture, and then that linear there on the skin, the wrist of the flexor portion there, and then Norwegian scabies down there in the corner. Those are usually really bad outbreaks, super itchy. But what you want to do, I have a smart phrase for this. It's really important that patients understand what they're supposed to do. First, they go home and they burn their house down. Then no, I'm only joking. So they go home and they say, I got to get rid of all my dogs. And I'm like, no, this is not from your dog. Dogs get mange, which is a different type of mite. You can't get mange from your dog, okay? You can look mangy, but that's not from a mite. So the treatment is this permethrin cream. And you can also use oral ivermectin. There's other different things on the market that you can use, and even some holistic things. But basically, come up with a smart phrase and put it in your chart because you're going to see scabies, all right? And you might even have scabies. We don't have time for my scabies story, but let me tell you, it took me months to get rid of scabies. And that is not a joke. It was a very, very dangerous place. And I got it. Who knows how I got it, but everybody had it. So it took me months to get rid of it. It was very upsetting. So imagine how your patients feel. They're coming back. They're worried about their kids. They're worried about visiting their family members. They don't know if they have to go stay in a hotel. So they go home. They take off all their clothes. They put them in a trash bag. They take a shower. They apply the permethrin cream from the chin down. Okay, avoid inside the vaginal area or around the rectum. But basically go to sleep in the morning, take off all the sheets from the bed, put them in the bag. Now the scabies can stay alive for about 72 hours, just so you know. So they can either leave it in the bag for 3 days or a year, whatever, or they can put it in the hot water and kill those suckers. And then they take a shower and wash off the permethrin cream. But they have to repeat this in 7 days, and they should treat their partner or family member because sometimes they don't have the itchy response from the mite, and they can just keep transferring it back and forth. Imagine our really difficult homeless population or treatment. I let them stay and shower in the department. You should try and help them do that as well. So let's move on to something else itchy. I really, every time, I'm very itchy right now. Head lice are on the hair shaft, and they kind of hang out on the scalp. Now, the reason why you can tell the difference between lice and scabies is because the lice, they like to be like these little black guys present on the scalp. They don't dig under the skin. They also bite all over the place. So if you take a look here, they just randomly bite all over. They don't form a real pattern. They're not as smart as scabies, I guess. But basically, you can get them anywhere. So, anywhere down there, up here, whatever. You can have hair anywhere. So if you have hair, you can get lice there. Again, the treatment for this is going to be putting all the stuff in a bag and washing it. And you can also use RID or permethrin nicks for the treatment of this as well. You only need to do it one time. Lice typically only stay alive for about 24 hours. So just keep that into consideration if people are asking. I mean, there's some good studies about how long these suckers like to live. Let's move on to some classic childhood exanthems. So these are rashes or outbreaks of skin eruptions, basically an exanthem, that are related to an illness. And they're not related to a mite or a bug or anything like that. And we first started naming these back in the 1700s, so we said, well, we see a rash, let's call it first disease, right? Yeah, we got first disease, and then, hey, this is kind of a different looking rash. We should call this second disease, and then so on and so forth. And then we got to fourth disease, and we're like, oh, just kidding, that's really just Scarlet Fever again. And then we thought, well, by the time we got to sixth disease, we're like, I can't remember all those numbers. So that's when we started giving them names. And the first one I want to talk about is measles. And unfortunately, I still have to talk about this because there are people that aren't getting vaccinated. But there are also countries that families can't afford to get the medical care and treatment, and measles is ever present there. And so those people can travel and bring measles here or there or anywhere, and therefore measles in our unvaccinated population is occurring. And remember, not all vaccinations are 100% effective. So after the first shot of the MMR, you only have about 93% effectiveness, and then it turns into 97% after the second shot. So just keep that in mind that it could always be measles, right? It's kind of like it could always be cancer. You hate having to say that phrase, but if you think that you have measles, then you might. And they're the 3 C's that I always remember. Okay, cough, conjunctivitis, and coryza. You also get a fever, and of course, the rash, all right? You first get these spots in your mouth called Coplic Spots. That's a great board question. And they usually appear about 48 hours before the rash. So again, whenever you see a rash, take a really great history because these patients are going to tell you stuff that's going to help you nail down your diagnosis. Oh yeah, like I noticed I was brushing my teeth and all of a sudden I just kind of looked in there and I had these spots. And then a couple days later I had this crazy rash and here it is. So that's a good part of the history that you can take. It's a macular-papular rash. It's erythematous, and it spreads from the head all down. At first, it's easily blanching, but later, doesn't blanch at all. And remember, measles can cause things like encephalitis, pneumonias, otitis, conjunctivitis, and can be especially harmful in all ages. Here's an example of the conjunctivitis you can see, and you can see this guy's rash. Oh, it's just red and irritated. And here's some other pictures of measles as well. One of the big things that I like to tell family members, and we'll talk about, here, before we get to that, if it's a little hard to see, kind of like they look like little pieces of sand or salt in there. As I mentioned, we've had a lot of cases due to unvaccinated individuals, but specifically in 2019, there was quite a large outbreak in the New York area, which I put up. I originally had a really great picture of the 2019 states. So basically 25 or so states had outbreaks of measles, which to me was just really amazing that we were dealing with this. And luckily we got that outbreak under control. But there's such a large population of travelers into the New York City area, it actually wasn't surprising. There was a large group of people that didn't want to be vaccinated. So here's the bottom line with Rubella or measles. Healthcare providers should consider measles in any patient presenting with a febrile rash illness that is compatible with measles symptoms, with the things we talked about: cough, coryza, conjunctivitis, who has been international or hasn't been vaccinated, and it's a reportable disease, okay? You can do an IgM antibody, blood specimen, or you can do a measles PCR, respiratory, and you can also use urine to test. You should be getting with your infectious disease specialist. You should also be talking to your attending physician, getting them involved. The best thing about any kind of rash, in my opinion, when it comes in, you should never feel bad about asking someone to say, hey, I really need you to come look at this guy's penis with me. I think it's herpes, but I'm not sure. Or I really need you to take a look at this person's armpit because I think that I'm not really sure. Share your rashes with everybody. I think if you say it that way, nobody will want to be your friend, but you could at least start off a conversation that way. All right, get someone to take a look. So remember what I said, members or other healthcare workers who cannot prove or show immunity, you can offer them PEP, the post-exposure prophylaxis. You can actually give them the MMR vaccine, measles, mumps, and rubella, 72 hours post-exposure, or you can give the IG within 6 days. And because this is a reportable thing, most likely you're going to get everybody coming in around day 1 or 2 because they're going to be worried about their exposure. So you should have a pretty good time frame of treating this. If they come in a lot later, I still would encourage them to get the MMR vaccine. But again, talk to your infectious disease specialist. There's no specific antiviral therapy. It's all supportive. So you need to address the complications and quarantine for a full 21 days. Well, we quarantine for a year, so 21 days is nothing, right? Okay, let's talk about rubella, sort of the mini measles, right? So it's an acute viral illness. You get a fever, sore throat, headache. It's a different virus than the rubella measles. The MMR does vaccinate for rubella. So this rash starts on the face and spreads caudally. It's pink, it's pinpoint, and it's maculopapular. It's called the 3-day measles. You get this low-grade fever and some lymphadenopathy, and you also can have complications from this form of measles as well. But there's one thing I'm going to say here about both of these issues, is that if you find that you have a fever lasting for more than 5 days, we're going down a different direction. Remember I said that we're going to try and pick out all the really bad rashes? I'm not going to spoil it yet, okay, because we're going to talk about it at the end, but it's Kawasaki's, so just keep it in the back of your mind. Could this be Kawasaki's? What am I seeing? Rash, fever greater than 5 days, but we'll get there. I just want you to keep it in the back of your mind for anyone that has a fever and a rash that's lasting a really long time in kids. So here's a great picture of a kid with rubella, or German measles. Here's an adult with our German measles. You can kind of see it's like this kind of fine, pinpoint, pink rash going down the side of his face and neck there. Let's talk about scarlet fever. So a specific toxin producing group A beta hemolytic strep, and this causes your sore throat, strep throat, fever, headache, vomiting, sandpaper rash. Okay, again, that's the board question, right? But that's really what it looks like. It starts about 12 to 72 hours after the fever, and it forms in that flexor crease as well, but not like scabies does. Let's take a quick look at that. This is Pastilla's lines in the flexor spaces. They're not bites, they're lines. And the patient has a really high fever. With scabies, you're not going to have a fever. So again, these are the little things that we use to differentiate our rashes. You also get a good history. So this guy, he was a Romanian doctor that discovered these particular this particular fever, and that's why, hence it's called that. And it moves from the trunk to the extremities, so it starts inside and goes out, right? So again, another piece of information that we want to get from our patient. Then they get this strawberry-looking tongue. There's a bright red, pink tongue with fine papules on there, and they get this skin peeling. It doesn't look like a burn. It literally starts to just kind of peel or flake off, like those little foot kits that you can get for those like pedicure things, if anybody has seen those. But basically, I'll show you some pictures of those. The skin just starts to kind of peel off. Not sloughing, but peel. And again, once you've seen it, you're never going to forget it. The treatment is oral penicillin for 10 days, and you do a throat swab, obviously, to diagnose it. And you could also do a titer if you are asked by infectious disease, which sometimes they do ask. So you can see, again, the strawberry tongue and the sandpaper rash. I talked about Pastilla's lines. Here is the skin peeling or the desquamation. You can see here on the hands. Here you can see on the feet, right? And again, this patient's going to have a fever, okay? And I'll put all the pieces together. And again, this would be a good time to use one of your apps, right? You're kind of like putting your diagnosis together and thinking, gosh, what rash could this be? You know, if you're kind of trying to think about what it is and what it's not. So let's talk about fifth disease. This is erythema infectiosum. It's caused by the human parvovirus. And this is often seen in the springtime, but you can see it pretty much any time of year. Usually get a fever, but not always with this. And this classic sign of fifth disease, it looks like you slap the kid around a little bit, right? You're like, oh, what's going on? Like, let me take a look at this kid. Oh no, this is very consistent lace-like rash on the face, the limbs, the trunk, and it's gonna go away on its own. Don't worry, mom, dad, everything's fine. You know, this is what it is, this is what causes it, and explain to them basically it is self-limiting. And the thing about this is that kids are pretty playful. They don't really seem irritated or bothered, but they have that classic look. They also have it sparing on the chin and on the eyelids. So you can see in this next picture, this kid doesn't have any of this on his chin. It literally looks like, you know, they've been hit in the face like that. And there's an example on the arms as well. What about rosiola? Again, another one that's probably going to get better on its own. This isn't something that we're rushing people in to be admitted or doing a bunch of tests. Once you see it, you will be able to know the difference between this and the others. So this is caused by the herpes virus, right? But make sure you explain to parents this isn't the kind of herpes that you get, you know, for other reasons. This is a different kind of herpes virus. There's lots of different kinds. So don't scare patients, family members, and explain it in a way so that they can understand. Very important. Very common in 6 to 18 years of age. They typically get a super high fever, and then this rash comes after the fever. In fact, some of the febrile seizures that you'll see will actually be related to this in the ER or your urgent care. They get these pink macules and papules on their trunk, and then that may spread to the neck, the face, the extremities. And again, symptomatic treatment. Here's an example of rosiola. Rosiola again. All right, let's talk about hand, foot, and mouth disease. Coxsackie virus or the enterovirus. Now, fecal-oral transmission. Like, this isn't supposed to happen, right? Things from your butt aren't supposed to go in your mouth, and you're not supposed to get sick from that, but it happens, and this is how we get it. So basically, this is occurring in outbreaks in usually families and schools, and it usually is from poor hand hygiene. You get these oral lesions. They're painful vesicles on the buccal mucosa, the tongue, the soft, but you're also getting them on your hands and you're getting them on your feet. And I'm going to show you some pictures. You might even see them on the butt as well. And again, symptomatic treatment, probably going to go away on its own. The key here is to avoid viscous lidocaine. You don't need to be giving these kids lidocaine. This is not something that has to be done. You could treat maybe with some Benadryl. If they're having trouble or they're having a fever, you can give them some Tylenol. Just remember that you don't want to give a bunch of this old school lidocaine to them. Here you go. Hand, foot, and mouth disease on the hand, on the foot. Let's look at that hand one more time. Foot a little more subtle. There it is on the tongue. Now this is very different from herp angina. Herp angina is, again, painful ulcers, but it's only on the posterior soft palate, uvula, and tonsillar areas. You're just seeing it in the back of the throat. So this is the patient that comes in, says they have a sore throat, doesn't look like strep, but they have these little lesions in the back of their throat, but it's nowhere else. So this is herp angina. Again, it's from the Coxsackie virus, but it just is a different type, all right? So essentially, you can have a fever, usually very high temperatures, sore throat, headache, and maybe a little bit of neck pain. But make sure you're not missing something else. Get a good history on these patients. Make sure you're doing a very good exam. And again, supportive treatment, let the disease run its course about a week. See there how the lesions there are just on the back of the soft palate, on the tonsils, on the uvula there, the top. All right, chickenpox. When I was little, I went to a chickenpox party. And sad about that, but I'm alive. I'm okay. Don't write my mom an angry letter. She gets enough of those from me. So Varicella Zoster is the cause of chickenpox. And the chickenpox, this is what the dewdrop on a rose petal, right? Dewdrop on a rose petal. We have some pictures. Again, once you see this rash, you're never going to forget it. But remember, people aren't vaccinating anymore, so you have to keep thinking about these things that we thought we got rid of. They're macules, papules, vesicles, and then crusts. They go very straightforward in that fashion usually of how they progress in the disease. Lots of complications, mostly in adults, right? Because they can get pneumonias, encephalitis, again, otitis. And the treatment here is antivirals, right? So acyclovir and valciclovir. You want to avoid salicylates. We don't have a lot of time to talk about Rye's syndrome, but that, again, is something important for you to keep in the back of your mind if you do make the diagnosis of this. So the prevention, of course, is the immunoglobulin if pregnant or immunocompromised, and the vaccine in kids and non-immune adults. There you go. There is the dewdrop on the rose petal. Very classic picture. Okay, I promised you Kawasaki's. I know you've been waiting for it, so here it is. Kawasaki's. Now, I've seen a lot of cases, believe it or not. And in a lot of cases, I mean probably 10, believe it or not, because I worked at CHOP, I worked in DC, and this was just something that I work with kids. I do a lot of pediatric stuff, so I'm seeing really sick kids. And I've diagnosed this a couple of times, and I've seen it lots of other times. But again, when I say lots, to me, that's about 10 cases. So it is a rare, I don't want you to think you're gonna see this every day. You shouldn't be, calling for every fever that's exactly 4 days and 17 hours, right? But these kids are really sick kids. They have a fever that is persistent. And when you find it, you're like, oh, okay, I got that one. Maybe I didn't fall asleep during that class. Like, I got this one. You really saved someone's life, because what happens is that the disease attacks the heart and the coronary arteries, okay? And that's what essentially kills them. And the treatment for this, they get the vasculitis, and the treatment is aspirin. And I'm sorry if I didn't put that on the slide there, but that is how we treat this. And sometimes there are other various treatments that we use. But again, this is clearly a case that you want to discuss with your partners in infectious disease and the pediatric specialist. There's also a major criteria that you want to look at. You're going to have conjunctival injection. You're going to have oral mucous membrane changes. So again, you can have that with some of the other rashes we talked about, right? Okay, you have to have peripheral extremity changes. Ooh, okay. Well, we did have that with hand, foot, and mouth, but it doesn't quite go. So I'm putting the pieces together of the rash. Then you have this polymorphous rash, erythematous rash, and it can start anywhere and go everywhere. And again, you have peeling of the skin. So again, we're hearing more things that we see, we're hearing the same things that we're seeing in our other rashes, but this is what's different. You start having the cervical lymphadenopathy, big nodes, and then the fever persists. Then these kids are uncomfortable. So you're going to do a white blood cell count, ESR, platelets, and again, the workup of these patients involve your specialists. And like I said, this attacks the coronary arteries. Oh, there it is. Aspirin and IV immunoglobulin are your treatments. Here's some pictures of the criteria that you can see in these kids. They're very sick little guys and girls. I like this because you can cut it out if you want and stick it in your cheat book. I also made a nice little infectious rash listing here as well that you can refer to. And who's itchy? Who's feeling itchy? All right, that's it for pediatric rashes, guys. Thanks for listening. And Jan is up next.
Oh. We're going to go from one visual talk to another. Are you ready for some really gross genitalia? This will wake you up, I'll tell you that. All right, we're going to talk about sexually transmitted infections, and there are actually some really pertinent updates in here that you may or may not be aware of, so we'll get to those. So if we divide our sexually transmitted infections into kind of two general categories, it can be helpful. There are those that ulcerate, things like herpes, and there are those that don't ulcerate, things that cause urethritis, stuff like that. So we're going to kind of walk through these lists. And let's start with one of the common ones, our old friend gonorrhea, okay? So remember that gonorrhea and chlamydia are BFFs. They like to travel around together, and often you see patients who are co-infected, and we often presume that co-infection is the case when we see patients who have discharge, who have urethritis, et cetera. We know this is very infectious. The CDC just recently put out a report that it's estimated that 1 in 5 adults in the United States has an STI. I mean, like, the incidence is really, really high. In men, in general, gonorrhea is pretty symptomatic. They may have purulence, they may have copious discharge, and they have dysuria. In women, they usually do have cervicitis, but they may not have as many symptoms, minimal to no symptoms. But when you take a look, you'll see that kind of friable, angry cervix, and they may have purulence. And we'll talk about PID and what you do when you have cervical motion tenderness, et cetera, in a little while. It's true that gonorrhea can also give you proctitis, and it can give you pharyngitis, although those are rarer than the other complications, but that should be on your list of things that can cause those things. And it can cause conjunctivitis, which is a really, really big deal when it gets into the eye. And gonorrhea can disseminate. We'll talk about that too. In terms of testing, these days we have nucleic acid testing, and we do this from the urine, which is a really common way that we test for it now. And if you think that it's in the eye or the pharynx or the rectum, that needs to be cultured if you suspect infection in any of these places, eye involvement as well. Here's one of the big updates. So the CDC updated their guidelines for treatment for gonorrhea just this past December, so only 7 months ago. They made an update, and they hadn't updated these guidelines since 2010. And you might remember that in 2010 up until now, they recommended for gonorrhea double treatment. They recommended that we treat with ceftriaxone and azithromycin, double coverage, because of emerging resistant strains of gonorrhea. Well, now the recommendation from the CDC is to go back to a single antibiotic regimen for uncomplicated gonorrhea. And they recommend give ceftriaxone at a dose of 500 milligrams IM. It used to be 250 milligrams IM, and now it's 500 milligrams. Why did they go back to only using a single antibiotic for gonorrhea? Well, there's a couple reasons. One is that we're very concerned these days with antibiotic stewardship. So treating something with 2 antibiotics, unless it's absolutely necessary, is thought to be not great antibiotic stewardship. In addition, using those 2 antibiotics was also thought to maybe be affecting resistance patterns in other organisms that might be around. So they decided to kind of curtail it back. It also turns out that cephalosporin resistance of gonorrhea was not going up at the rate. It looks like it hasn't been going up at the rate that they were worried about. So they could kind of go back and tailor it now to just be a cephalosporin, 500 milligrams IM. Now, if chlamydia has not been excluded, and in many cases it hasn't in terms of emergency practice, because we see patients who are symptomatic, and we may not have this test back right away. So often we treat the 2 infections concurrently. And so we'll also give chlamydia treatment. And it may be to cover the chlamydia. But be clear in your mind that that's what you're doing, that you're not treating the gonorrhea double coverage anymore. Gonorrhea is just a ceftriaxone. And you can use just doxy then to treat the chlamydia for 7 days. So you have a couple options there, but it's important to know that the CDC has now tailored it back to just being 1 antibiotic for gonorrhea. If they actually are over 150 kilograms, they want you to up the dose of your ceftriaxone to 1 gram, which is also different. Now, this recommendation has just been updated for just uncomplicated gonorrhea infection. So we'll talk about the more complicated ones, and the recommendations there haven't changed quite yet. So every once in a while, you're going to see a patient who has disseminated gonorrhea. It's not that common that it happens, but it's interesting when it does. This is someone who just doesn't feel well overall, because now it's disseminated, so they may have fever. They often have joint pain. They may have actually polyarthritis and even a tendinitis as well. And it can also cause septic arthritis, that you can have a septic joint from gonorrhea. Interestingly, when you see this, you have to look for these skin lesions. And you see an example here. It's this hemorrhagic little lesion on a red base. And that's when you kind of suspect that it's disseminated gonorrhea. Now, when you do see disseminated gonorrhea, you want to look at all the possible sites that this could be coming from. So you've got your typical urethritis type of thing, cervicitis, but you also want to think about the proctitis and the pharyngitis as well. And if there's a joint to tap it, often those cultures are negative. So we usually are making this a clinical diagnosis. And if you think this is what's going on, you start the ceftriaxone. You start the ceftriaxone at a dose of 1 gram given parenterally, so IV or IM. And the recommendation for this is still to double cover with azithromycin. This may be updated at some point in the near future, but right now that's still technically the recommendation if you go and look on the CDC website. Now, chlamydia is the disease in the United States, and it can cause urethritis, it causes cervicitis, much less symptomatic than gonorrhea, and it can even be asymptomatic. So sexually transmitted young adults are actually recommended to get screened for this because it can be asymptomatic, and you could be walking around with it spreading to other people. It has a high complication rate in women because of that asymptomatic nature. People go untreated, and it can cause scarring, etc. So it's something that we know is asymptomatic, and we want to have a low threshold to treat. In terms of diagnosing it, again, I mentioned that you can do urine nucleic acid testing, and that's one way to get at it, and we want to treat it with either doxy or azithromycin. Either one of those are acceptable options. Now, PID, if you really think about the words pelvic inflammatory disease, is such a general term. Inflammation of what in the pelvis? And that's because actually this is an ascending infection in the pelvis that can affect multiple structures in multiple ways. It can be the endometrium, it can be the fallopian tubes, or peritoneum, can by themselves and alone combination, can really be an ascending infection of any of those structures. And it can also cause a tubo-ovarian abscess, which is one thing we think about. The concern here, if we don't treat it, is that, again, you can get tubal scarring and risk for infertility, chronic pelvic pain, and even ectopic pregnancy. And this has been listed by the WHO in terms of worldwide health as something that clinicians need to have a lower threshold to treat because it affects people all over the world. Now, really, PID, although we talk a lot about GC and chlamydia being etiologies, it's really a multi-organism infection. And often, if you culture these, you don't just get GC and chlamydia. You can get mycoplasma, you can get lactobacillus, so it's an infection. Now, patients can have PID and be very mildly infected and look pretty good, all the way to being quite sick, so a wide spectrum of disease. And our goal is to make sure we catch those ones that aren't too sick, and for the ones who are sick, that we're catching what is going on in terms of, is there a tubo-ovarian abscess, that we're not missing something like that. Now, PID is a clinical diagnosis. It is a clinical diagnosis. So yes, you're going to send some tests, but PID is a diagnosis you can make after you have examined someone, taken a good history, examined them, and determined that this looks like PID before I even get any tests back. In those diagnostic criteria are cervical motion tenderness or uterine tenderness or adnexal tenderness. And I can't make this diagnosis unless I've adequately examined someone. So if we talk about the pros and cons of, for example, doing pelvic exams at all in women, one of the reasons that you still need to do a pelvic exam, because without knowing if they have this clinical tenderness, you can't make this diagnosis. So it's an important thing to do. If they have any of the above, you want to treat them presumptively based on your clinical exam. It's a clinical diagnosis. And if they look sick, if they're very tender, they don't look great, that's when you image them. You image them looking for an abscess. Now, a lot of PID can be discharged, and there'll be a certain percentage that need to be admitted, so it depends on how your patient clinically looks. Are they tolerating POs? What's their pain level, comorbidities, etc.? How compliant are they? There will definitely be outpatient failures, so this is one of those diagnoses where you want to make sure there's a follow-up plan, and a good understanding that follow-up is important, because there will be people who fail outpatient therapy for PID. There's a bunch of different treatment options that you have. You can always look these up on the CDC website. There's IV treatment options, there's oral treatment options. Pretty common to use ceftriaxone and doxy. Again, note for PID, we don't use ceftriaxone and azithromycin. We use ceftriaxone and doxy for PID, and it's for a longer course for 14 days. You may or may not choose to add metronidazole as well as an additional agent if you choose to do so, and if you discharge them home, they should have a recheck set up in 2 or 3 days. Now let's talk about herpes. This is the most common ulcerating sexually transmitted infection in the US, and again, estimated that up to 1 in 5 adults are infected with herpes, we know that this is something that we can't cure, but we can manage. The HSV2 type is the more common, but it can be HSV1. And if you've ever seen someone with their first outbreak of herpes, boy, you feel so sorry for them. They are in so much pain, very uncomfortable, don't feel well in general. And that initial infection can really cause someone to look not well at all. They can have malaise, they can have headache, they can have adenopathy, et cetera. I've even admitted people for their first outbreak of herpes because they're so miserable. So that usually happens really in that first episode. They get their primary lesion 2 to 7 days after the contact. These are very painful ulcers. They're clustered on erythematous base. They can also sort of coalesce and just make a larger area of pain, and pain on contact is really common. Those local symptoms will peak in 8 to 10 days, and then it will take a few weeks to kind of go away. And we know that this patient can also shed virus as well during recurrence. Even when they're asymptomatic, they can shed virus. This is a clinical diagnosis. You're not going to have any test that comes back to you in the ER to tell you that this is herpes. It's a clinical diagnosis. It's the right story, it's the right looking lesion, etc. Now you can do viral testing on women, especially those of childbearing age if you want to, but in general this is a clinical diagnosis and then you refer. Most patients will have a symptomatic recurrence, and so there is an educational component to this, that this will come back, unfortunately, and so letting people know that that's a possibility is important. And often before it comes back, you may have a prodrome where you get some burning or you feel a little bit of itchiness or numbness, and you kind of know it's coming back. Should we treat with antivirals? And the answer is generally yes. For that first episode, absolutely. Does it cure it? No, but it can shorten the whole duration of the misery for sure. After that, we know that treating with antivirals can decrease the amount of virus that's shed. They can decrease the amount of the length of the symptoms that people have. And any of these antivirals, for example, acyclovir, valcyclovir, famciclovir, et cetera, is all fine. The dosing and how long you treat for depends on which drug you choose and whether it's the initial outbreak or recurrent versus using it as a suppressive therapy for some patients who have frequent recurrences. And as I mentioned, it's not out of the question that someone might need to be admitted, especially with that initial episode, and if they have any kind of other complications, and that often occurs in the setting of immunocompromise, that may be another patient that needs to be admitted. Now, syphilis is on the rise as well, and it's not uncommon to see syphilis. It's still the old spirochete, treponema. It causes the primary infection is the chancre, the painless genital ulcer, which patients don't often seek treatment for because it's painless. It's an indurated vesicle with a sharply demarcated border. It tends to just go away on its own in a week or two. It'll just kind of, a month or two, it'll go away on its own eventually. It has a wide incubation period. And we know that dark field microscopy has some good sensitivity to it, but generally these days we're sending serum tests. And we used to start with, at least in LA County, they've recently changed the way they do syphilis testing. It used to be we would send the RPR, which we knew was kind of non-specific, and if it tested positive, you would send the more specific VDRL and treponemal antibodies. And now they've implemented, at least in LA County, a reverse syphilis screening algorithm where we start actually with the more specific test, the treponemal antibodies, and we work our way backwards, which is interesting. So there may be some recent changes depending on your healthcare system as to how you test for syphilis. Remember that if the primary syphilis goes untreated, we can move on into the secondary and tertiary phases of syphilis. Secondary phase of syphilis comes a couple months later, after the chancre's gone away, and all of a sudden this rash comes. And this is a very non-specific rash. It's a maculopapular rash. It often is on the palms and soles, which they're kind of a specific list of things that cause palms and soles rashes. So anytime you see palms and soles, think about it. They may also have some fever and arthralgias. They can have condyloma. They may have some painless lymphadenopathy. But this is why syphilis is called one of the great masqueraders, because this rash is pretty non-specific. And in fact, when I'm seeing people in the ED with a rash that I'm not sure what it is, syphilis always crosses my mind because it can look a lot of different ways. It's not an itchy rash. And so when you see rashes that you're not sure, think about syphilis. I learned a long time ago a good phrase when it comes to rashes, which Martha's talk made me think of, which is, if you know what it is, why touch it? And if you don't know what it is, don't touch it. And I kind of live by that. So that's kind of a good little axiom in terms of treatment of rashes. And so syphilis makes me think of that because you wouldn't want to touch it. Latent disease, if you have untreated syphilis for many, many years, it can do some really interesting things, up to decades after that initial infection. You have neurosyphilis on the list for sure, but you also have things like cardiovascular syphilis, where you can get aneurysms and you can get aortic insufficiency, and it can cause weird skin lesions and cause Charcot's joint and what is it called? Tibialis dorsalis tibialis. What is it called? I can't remember what the name is of the syphilis, when it gets into the posterior column and causes the balance problems. Yeah, tabes dorsalis, that's it. Tabes dorsalis, that's what I'm thinking of. So syphilis still hasn't emerged in terms of lots of resistance. So penicillin is still the recommended treatment for syphilis. It's the benzathine penicillin that you want to give, 2.4 million units. It's an IM dose for primary and secondary. And remember that when you give someone who has syphilis the penicillin, you can cause the Jerisch-Herxheimer reaction. I love that word, Jerisch-Herxheimer reaction, which is basically the penicillin going after those treponemes. And the treponemes are exploding and the person doesn't feel very well. And that can happen with treatment of syphilis for sure. Now let's move on to some little bit more unusual STIs to talk about, Shankroid and Lgv. Now these are actually fairly rare in the US. They happen in little sporadic outbreaks in different parts of the country, but often these are things that may be acquired overseas, for example. These cause genital ulcers plus also some very painful adenopathy that you can get in the inguinal region. This is often a clinical diagnosis. The treatment of these more unusual infections varies and is not worth remembering because you won't see them as frequently as you would need to put something in your brain, so you can always look it up later. Lgv is something that's caused by chlamydia. It causes painless, shallow ulcers that really get better quickly, but they get these buboes, which are these big nodes that happen as well. And so, one thing about these types of STIs that form these granulomas and these different adenopathies in the inguinal region is that this is one of the reasons you don't want to go INDing things that kind of pop up in the inguinal region. It could be that it's a node that's coming up. That's not something you want to IND. So be careful when you're thinking abscess in the inguinal region. Just ask yourself, could this be an adenopathy for some reason that I don't really want to go cutting into or exploring? So just keep that in mind as you're looking at bumps that happen in the inguinal region. So just to summarize here in terms of ulcerative STIs, we have herpes, we have syphilis, we have Shankroid, and we have Lgv. And this kind of is a nice summary slide walking you through what those symptoms look like. Does it have systemic symptoms going with it, systemic illness? Does it have any adenopathy? If so, how would you describe it? What is that initial in general in terms of how they're differentiated one from another? A nice sort of summary slide. Now let's move on to some other genital presentations, some of which are sexually transmitted and some of which are not. But let's talk about someone who comes in with a complaint of vaginal pain or vaginal itching and talk about vulvovaginitis. So certainly these are pretty common chief complaints. This could be from an infection of some kind, but it could be from an irritant or an allergy or some kind of vaginal foreign body. It could be from something like atrophic vaginitis that we see in older women, but it's a really complaint. Now, in terms of Canada, which is definitely common, this is, probably a quarter of the cases of vulvovaginitis that you see, and it's very common for women to have this at some point in their lifetime. We know that this is generally Candida. There are risk factors for this. Diabetics can get this, people who've been on recent antibiotics, people on OCPs. Pregnancy can make you more likely to get Candida. And when you see candidal infections, I want you to think about diabetes. And the reason is because, we see so much diabetes in the US. And often that initial presentation might be something like a candidal infection, or in men, balanitis that's caused by Candida. And it may be their presenting symptom of their diabetes. So doing a glucose check is so easy to do, and you may pick up somebody's diabetes in that case. The other thing to think about with candidal infections, especially if a woman is getting them recurrently, is to think about HIV, undiagnosed HIV in that patient. So consider that as well. This is usually presenting with a lot of itching. It can be very intense. They may have some discharge. They might describe it as that kind of cottage cheesy looking stuff. They may have dyspareunia as well and dysuria, which is more described as an external dysuria. Sometimes when women are describing dysuria, you have to kind of get at exactly what they're describing. Is it when the urine is sort of leaving the urethra that now it burns, or is it really when it's passing through the urethra that they're having pain? And sometimes that can help you clue into whether or not this is really a UTI or something that's more external to the urethra. And when you take a look, you see erythema, you see some edema, you may see that discharge, and sometimes it's not present, but you do your wet mount and you see the Candida report come back to you. So we generally do a wet mount. You can see the hyphae. If you happen to send a wet mount for some other reason and they really have no symptoms of Candida, you don't have to treat if they're actually completely asymptomatic in terms of the Candidal. Although I don't know why you would be sending the wet mount if they were completely asymptomatic, but that is what the recommendations say. In general, the treatment can be either topical treatment or really what's more convenient for most people is oral treatment. So fluconazole given just orally 1 dose can really take care of it. But sometimes people prefer the topical treatments for whatever reason, and that's fine. If it's pregnancy, though, you use the topicals, and that's what's recommended. Again, I recommend checking glucose levels. It's so rampant that people that have diabetes, especially young people, they don't know it, and if it runs in their families, if there's any other suspicion, just do a quick glucose check. You may find an undiagnosed diabetic out there. Now, what about trich? This is another thing people can present with discharge. Now, Trichomonas, which is a flagellated protozoan, is a sexually transmitted infection, and it's important to talk about it that way with patients as well. The presentation can be anything from asymptomatic to various complaints of different types of discharge. They may have local itchiness as well and irritation. When we take a look on exam, sometimes you see the strawberry cervix, but that's the kind of the classic thing you read about in textbooks. It's not clinically actually that common when you take a look, but you will see discharge for sure. Again, you do your wet mount swabs taken intravaginally, and you'll get the report back of the trich. You'll see a lot of white cells and the motile trichomonads. The treatment here is metronidazole. You can also give tinidazole as another option. You give it orally in a single dose. You can also give a 7-day course as well. The gel is not that effective for this. And again, I mentioned that this is sexually transmitted, so it's important to do some education about how the partner needs to be treated as well. This is one of those infections that tends to get passed back and forth if the partner doesn't also get treated. So this is an important one to know about, and it's the most common non-viral STI in the United States. So BV is another thing that people can come in with. This is when they basically kind of get an alteration of their normal vaginal flora. This is not sexually transmitted, also important to communicate with people. And your exam may also be relatively normal, but it comes back on your wet mount that you see the clue cell. That's the report that comes back to you. The CDC technically has these different criteria depending on what you're faced with, but most of us aren't doing pHs. We're not doing the fish whiff test. We're really setting the wet mount, and we're getting back those clue cells on our report. People who are symptomatic, we're going to treat for BV, and for pregnant women, if you get clue cells back, we're treating all of them no matter what, because we know that bacterial vaginosis can increase the amount of preterm labor and rupture of the membranes, et cetera. So these are patients that we treat more generously. If they're pretty much, again, asymptomatic, you can treat or not treat. But the treatment here is metronidazole, milligrams orally twice a day for 7 days, or metronidazole gel. You can also use Clinda as an alternative. So in terms of vulvovaginitis and the exam and symptoms, here's another nice kind of chart that sort of outlines for you the frequency by which you'd see these various symptoms in patients who have these conditions. So for BV, for trich, for Candida, how many of them would have discharge, pruritus, how much of them have complaint of odor, can have some abdominal pain, erythema on exam, discharge, et cetera. Kind of a nice summary slide of the symptoms that go with each one of these types of infections. Now, in terms of the diagnostic testing, just reminding you of what your wet mount will come back with. You've got your BV, you've got your trich, you've got your Candida. Some of them, the trich has the white blood cells on it. The clue cells means BV. The trichomonads means trich. The yeast is Candida. And the only one on this list that's sexually transmitted is the Trichomonas. Now, patients who come in with chief complaints of vaginal pain or vaginal discomfort, you may find something like this, the Bartholin Cyst or the Bartholin's abscess. When you get the blockage of the Bartholin's gland, you can get these very, very painful abscesses that we deal with, and we IND these like any other abscess all the time. Now, they can just have a cyst, so maybe they have a bump there, but it's not necessarily red and angry, and that's a Bartholin cyst, or that cyst can become infected, and that's a Bartholin's abscess. They're very painful. They need the IND. It's not a pleasant procedure, but boy, it can bring a lot of relief. And if they're recurrent, if they've had these over and over again, they need to be referred to GYN for marsupialization or a surgery to basically stop it from recurring and recurring and recurring. Now, how do you IND these? There's various ways to do it in terms of how you leave something in there. So the word catheter, it's almost like a little mini Foley catheter, is probably what most of you have learned. But there's other techniques that you can do as well in terms of putting something there. So there's different ways that you can put little rings of little catheters, things like that to keep it open. You can look those things up, but there are some different ways to deal with these things. Now, condyloma might be something or that you happen to see on your exam. These are warts, anogenital warts, often coming from HPV contact. These are not painful, but they're often cosmetically concerning to patients. And again, it might be something that you happen to incidentally see as you examine patients. Now, there is a vaccination now for HPV that's out there for young adults, so perhaps we'll see less of this as time goes on. We'll see. But these can happen in the perineum, they can happen on the penis, anywhere in the genitals and the perirectal areas as well. And again, as I mentioned, they're usually painless and asymptomatic, but some people, it bothers them, they feel the bumps, they know something's wrong, they'd like a diagnosis. Typically, these aren't something that's emergent to treat, but you can give things like imiquimod. There's some little different topicals that you can use, but these can also be dealt with cryotherapy or frozen or surgically removed. And so remember that there is the vaccine out there, so we'll see how the incidence of this goes on throughout our careers. And we're going to close up here with talking about sexual assault. And, obviously these are patients that have been through a tremendous amount of trauma, and you may or may not work at a sexual assault response center somewhere where you do that exam or you may be referring them. But certainly knowing what the medical treatment of this and the medical aspects is important. So if somebody is a victim of sexual assault, and it happens to all genders and all walks of life, you want to send testing. You want to send diagnostic testing at that point. And of course, there's a discussion to be had about forensic exam, whether or not you're going to be the one that's examining the patient or whether you're going to be referring them for that forensic exam. If you are the one that is going to be examining them or doing any kind of diagnostic testing, things that you would send would include a wet mount. You'd be looking for all the general sexually transmitted organisms as well, and you'd also send serology, things for HIV, for Hep B, etc. In terms of how to treat, technically if you look this up, the CDC hasn't yet updated this gonorrhea treatment to be what I mentioned before, to the 500 milligrams IM, but I think all of us would probably do that at this point, now that the uncomplicated gonorrhea treatment has changed to the 500 milligrams IM, I would probably give the 500 milligrams IM, and that's what I would treat for the gonorrhea. In addition, you can add metronidazole, you can also add azithromycin in terms of your chlamydia coverage, and most people would also add herpes prophylaxis in terms of giving valcyclovir if you have a completely undifferentiated situation. That's not a CDC recommendation, but it's kind of a common sense one, and many people would do that. And emergency contraception is also something that we want to offer as well, of course. In terms of HIV prophylaxis, it kind of depends is the answer. It depends on the type of exposure. It depends on what kind of, if there was penetration, et cetera, the details of the assault, because there are varying levels of risk depending on what actually happened. And so the answer is it depends. You have to get some idea of what exactly happened, which will lead you to a discussion of what the actual risk is. If there is a 1-800 exposure line that you can call if you want any expert recommendations on this as well, and often your institution may have a policy of how they approach this, who you call to get recommendations from. But these treatments are not without their toxicity. So again, you want to assess the risk and decide on a case-by-case basis whether or not this will be offered. All right, thank you very much for STIs, and Diane's up next to finish off acute chest.
If that's not a libido killer, I don't know what is. And this is one of those things where what plays in Vegas may not stay in Vegas, so be careful. All right, let's finish up adult chest disorders. So I've been sitting over with my post-prandial, post-PF Chang's, ultra salty, my mouth is really dry, soy sauce, meals, sleepiness. So I suspect you all are too. I'm going to end with, though, this whole day, I'm wrapping up today, with PE. I want to talk a little bit about PE before we get into the details. I guarantee if you work long enough in a busy enough place, you're going to miss a pulmonary embolism, or 2 or 3 or 10. It is an extraordinarily wily, devious diagnosis. It is an entity that can be anything from as subtle as a little tiny bit of shortness of breath or a tachycardia that's unexplained to dropping somebody dead in their tracks. It's one of those things, and if you think about what we're trying to do with PE, we're trying to diagnose a clotting disorder that can be lethal, and we have to be as accurate as we can carefully to make sure we pick it up. But we don't want to do too much testing, because we know doing too much testing isn't a good idea. We radiate people unnecessarily, et cetera. And we can't default to, well, I'm not exactly sure if you have a PE or not, so I'm just going to treat you anyway. like we can sometimes with pneumonia. I'm not really sure, but I'm a little concerned, or let me skip it. The reality is I can't default to treating you for PE because that is the most lethal category of drugs we prescribe. So I have to be, you're walking this really delicate pathway that is so easy to fall off of all the little stepping stones along the way. So part of what I want you to walk away with today is accepting in your DNA that you are going to miss a case of pulmonary embolism. What I also want you to walk away with, though, is a thoughtful, reproducible, kind of algorithmic decision tree so that when you do miss that case of pulmonary embolism, you will know how you got there and that it is a completely defensible, justifiable, accurate, appropriate thing that happened. We will never pick them all up without doing harm. We will miss some won't be a harmful thing, and every once in a while it'll be a horrible thing. The key is this is an extraordinarily complicated diagnosis to try to make. Now, the good news is you're gonna walk out of here in 20 minutes or after the Q&A, knowing that you do have a way to get at this. You do have something you can do every single time when you're approaching somebody who might have a PE. So let's get into it. We know that PEs, just any kind of clotting, any kind of venous thromboembolic phenomenon requires three things. We need stasis of some sort. So the blood, instead of flowing at its nice rapid rate that it's doing through your body right now, in a certain part or even throughout the body, it's sluggish, it's stasis. I'm immobilized on an airplane for 12 hours. I'm post-op and I'm lying in bed in the hospital for 5 days. The immobilization causes stasis. Or I'm somebody who just has bad circulation. I am a CHFer and I just have really bad circulation. Or I have COPD, which also increases the risk of having a sort of static stasis event. So I need to have stasis. That's point number one. Point number two, something in my endothelium has to be a problem. I have to have damage to my endothelium, which is probably where a lot of the COVID clots came from, by the way, is endothelial damage. We're not 100% sure where they all came from, but that may be part of what happened with COVID. We know for sure, though, that this endothelial damage happens with things like trauma, who are smokers. We know we do that when we put in IV lines. Think about the number of people now we treat as outpatients for IV kinds of infusion therapies at home with antibiotics that are being given or drugs that are being given at home with indwelling catheters. Well, that's endothelial damage that can cause a nidus for that clot to form. And then finally, hypercoagulable state, which is another thing COVID probably did. We really don't know why COVID made so many people clot, but it sure did. We know cancer is a big one. People with cancers tend to be hypercoagulable, some more than others, but the reality is cancer patients are hypercoagulable. Hormones do this, especially pregnancy is an issue with hormones sort of fluxes, and hormone therapy does this. Big one, lupus anticoagulant makes people clot. It just it increases the risk of clotting. We know that. And we know that certain things like nephrotic syndrome, I'm peeing out. When people have nephrotic syndrome and all that protein is going into their urine, one of the things that's going into their urine in those proteins is antithrombin 3, which is one of the things that keeps you from clotting as it floats around in you. Well, they lose that. So they have disproportionate risk of clotting because they just don't have that balancer in their system as well. So stasis, makes sense of who's at risk. Endothelial damage, again, it makes sense who's risky there, and something that makes you hypercoagulable. So you already know the people that are a setup for this, for getting venous thromboembolic disease. When it comes to PE, what I wish would happen is that PEs would go read the textbooks that we learn from, because they don't read the textbook. I would love it if every single person with a pulmonary embolism said, oh wow, I got abrupt onset pleuritic chest pain, hurts worse when I breathe, I feel short of breath, oh my pulse ox, look at that, it's low, oh check out that leg, it's big. They're not like that, right? People will come in with PE, anything from I dropped dead when I got off my 12-hour plane flight with my big fat leg, or they'll come in with, I don't know, I'm just a little short of breath, or gosh, I don't know, I'm feeling palpitations, and they sit in sinus tach with no other reason to be there. They may be, my favorite case of PE getting diagnosed would be like me standing on a stage at a conference and somebody like you watching that person speak and noticing that she seemed short of breath, that she kept taking breaths after every 5 or 6 words. And that person in the audience, God bless them, a medical person came up and said, have you had any problems with feeling short of breath or any chest pain recently? And I'll be darned if that person didn't observe that woman's breathing pattern as she lectured and diagnosed a PE. It can be something subtle. That woman up there had no idea she had a pulmonary embolism, zero, none. So the symptoms, when they're classic, is wonderful. Don't expect them to be classic. Okay, so that's point number one. Don't expect them to be classic. They may be, but they may not be. The other thing, I would love a chest x-ray to show me somebody has a pulmonary embolism. I'll tell you, what is more helpful to me is that's not what happens, right? You'll have some findings that if you get them, it's like, cool, I'm going back to Vegas and I'm gonna start betting money. What tends to happen is the x-ray is normal, but the patient's not. You walk away from the bedside and the patient's maybe short of breath. They're no reason to be, their exam is fine, but you notice they're speaking and taking a breath about every 3 or 4 words. No reason to be like that. It's like, wow, something's funny. Look at the x-ray. That x-ray is, gosh, that's a normal x-ray. Or my pulse ox is low in this person. Gosh, that's a normal x-ray. That's the Hebe sense. That's a spidey sense saying, oh, whoa, whoa, whoa. Whatever's making them hypoxic or whatever is making them feel short of breath isn't something parenchymal here. It's something else. That negative chest x-ray actually, it makes me creeped out more. It's like, oh my gosh, it's like, why is that so normal when the person is not? A normal chest x-ray actually is highly concerning in the right clinical setting for pulmonary emboli. And remember, it is commonly completely normal. If you see things like, oh, let's say a Hampton's hump. I mean, you learned about these in school, right? Westermarck sign, the sort of triangular thing that's out at the periphery. Or, God, this poor baby here, this person should come to Vegas because they got both on the same chest x-ray. That's like, what are the odds of that? So these things, if you see them, great. And honestly, a lot of these things, you're not necessarily even thinking about PE. So for instance, let me give you an example. If I go back to these, people with PE can come in with, oh, let's see, a temperature of 100.4, a little bit of prolific chest pain, a little bit of shortness of breath. Well, the first thing that comes to my mind with that would be an infection. And I'm going to look at this and I'm going to say, well, okay, sure, there's my pneumonia. Maybe not. Because we know PE can cause a low-grade fever. It can even cause a little bit of wheezing. You might look at this and think, oh my gosh, it must be asthma. No, so be careful with these. These, I think, honestly, if we were to be given these just blindly, most of us would consider these infiltrates like infectious kinds of infiltrates. They're not. Okay, these are actually what PEs can look like on a chest x-ray. The other thing we look at is all these, say again, by the way, just as an aside, if you're getting a theme here, they lied to you in school. They lied to you, they lied to you, they lied to you. They told you, oh, people with pulmonary embolism have S1Q3T3. Again, if they do, come back to Vegas. They get it sometimes. It's not pathognomonic on the EKG to see that. If you see it, that's fine. There are things to look for on EKGs, but most EKGs in people who have PEs are normal. And if they're not normal, it's because that PE is big. That PE is causing trouble. So if you see, for instance, sinus tachycardia that's gotten big enough that it's gotten the attention of that person's autonomic nervous system, it's gotten their attention to say, whoa, something happened here, a little hypoxia issue, there's a clot in here causing some discomfort, something's funny here. But you can also see all of these things. So this is an EKG that has theoretically everything on it that a PE can do. S1Q3T3, so S wave in lead 1, Q and T, inverted Q wave and an inverted T wave in 3, S1Q3T3. That thing, if you see it, great. By the way, it's not pathognomonic, something to certainly think about in the right clinical setting. And if you see right-sided heart strain, so I see big prominent R waves. I see inverted T waves in the anterior leads, the right-sided heart strain. My PE is sitting out in the lungs, and my poor, weak right side of my heart, which isn't all that strong. The left side does all the work. The right side just has to kind of push it through this low-flow pulmonary tree. Well, all of a sudden, there's pressure in that tree because there's a blockage. My right heart goes into heart strain. If you see, by the way, those people, it's not the EKG is not going to be the only thing that's going to clue you in. That person has a big enough PE that the heart is struggling. So you're going to have them be tachycardic. They are going to be hypoxic. Those people are sicker. So the EKG is usually normal in those PEs that we tend to miss. It's not, if it's a bigger PE, we don't tend to miss those. We're better at those. Now, one of the temptations is, and back when I trained in internal medicine, I'm embarrassed to say, I was taught that I was never to admit a PE patient without a blood gas on the chart, an arterial blood gas on the chart, and to get that AA gradient and calculate that AA gradient. Well, it turns out we were wrong. 10% of people with pulmonary, in fact higher, 10 to 15% of people with pulmonary emboli have a normal AA gradient. It didn't cause enough VQ mismatch to change my AA gradient. My blood gas is fine. So it turns out that a blood gas, all it does is makes you make a mistake. So if you suspect a PE, well, yay, you still go on your path. If you suspect a PE and the blood gas is normal, you tend to stop and guess yourself. This test isn't good enough to let you do that. Do not get a blood gas in people you are suspecting pulmonary embolism. It's not recommended by any organization that has any kind of guideline on this. They all say don't. So don't get a blood gas. ABG, VBG, none of them. It just tends to lead you down the wrong path when you really should be continuing your decision process. Now, we know we use D-dimers when we work up PE. I'm coming to the algorithm in a sec. This is one of the tests we use. So we talked about chest x-ray, what it does and doesn't do. We talked about using the EKG, what it does and doesn't do. D-dimer, which is a breakdown product of a clot. So you make a clot and you break down some of that clot. And it's one of the things that's in your bloodstream. We know it has a role in diagnosing or in our algorithm for pulmonary embolism, but it has a very focused role. You only, or please do not click the D-dimer on your click crazy mouse thing that we can do. Don't click D-dimer unless you've risk stratified the person first. You've walked out of the room and you've either decided, in my gut, in my gestalt, I think it's a low risk, high risk, maybe a tweener risk, or I've actually done some sort of scoring system to tell me low risk, high risk, tweener risk. Don't order it everybody because we know the road to hell is paved with D-dimers and BNPs, and things that don't really help us necessarily clinically and can really do us some harm. So, if the patient, the patient comes in short of breath and they're wheezing, and you go in and you listen to them, and they're wheezing, and they say, yeah, I have some chest pain when I breathe, and I'm feeling short of breath, but I always have chest pain when I breathe and feel short of breath when my asthma kicks up. There's nothing different about this asthma exacerbation than every other one I've ever had. Don't go into the D-dimer anywhere. That person's having an asthma exacerbation. Trust that. But if not, if it's like, oh, no, I actually don't usually get pleuritic pain when I get my asthma. In fact, this is really bad and it happened all of a sudden, and that's not typical for me. Okay, now I'm worried. Now I'm getting more worried. What I need to do at that point, though, is I'm not the no risk category. Now I'm in the some kind of risk category. I need to stratify. I need to stratify that person. Oh, by the way, one more thing about D-dimer. Two more things about D-dimer. D-dimer, we have cutoffs that we all have at our hospitals for yes, no, it's positive, it's not. It's elevated, it's not. We have cutoffs. It turns out that we know that certain physiologic changes happen in certain kinds of states. One of them is aging. We know that as we age, our normal D-dimer tends to go up. We're just kind of, our vessels aren't quite as smooth anymore. We're forming and breaking clots up a lot, all the time, a little bit. So our D-dimer's up a little bit. It's just, that's a normal physiologic state of aging. So if you use a cutoff in a 70-year-old that's the same as a cutoff in a 20-year-old, you're gonna end up working up too many people for PE who are older. One of the things that has panned out that we can do in our decision trees is to use what's called an age-adjusted D-dimer. In people over the age of 50, it is their age times 10. So I'm 63. You're going to take my age and you're going to multiply it times 10. So my cutoff for normal is 630 or less. So if my D-dimer comes back at 590, that would be abnormal for a younger person, but for me that's spot on fine. So use age-specific cutoffs, but be careful with pregnancy cutoffs. I'm going to tell you about a study in a little while that says we may be able to use these safely, but right now, be careful using cutoffs of D-dimers on different trimesters of pregnancy. We know it tends to change over pregnancy. It tends to change as you go along in your pregnancy. Be a little careful with that. We're not quite ready for prime time as far as my read of the literature on that. Okay. One of the reasons we want to risk stratify is you don't want to order every test in everybody that where PE crosses your mind. One of the things I was told early in my training, gajillion years ago, was if PE ever even crosses your mind, work it up. We can't do that. It's not, first of all, it's resource overutilization. It's x-rays we don't need to give people. And I'm smarter than that now, and I have more data than that now, and I know that there's a better way to do it than that. So risk stratifying is really important. And you end up usually in a yes, I'm worried, No, I'm not worried. Kind of low risk, high risk, likely, unlikely. There's even some tweeners in there, but basically I'm sure it's a PE. So I got off the plane, my leg is swollen, I had abrupt onset pleuritic chest pain, my saturation is 88% on room air, and my respiratory rate is 25, and my heart rate's 130. Well, my goodness, that is a pulmonary embolism. I'm not going to order a D-dimer in that person because that's just good. If it's normal, it's a perfect test. So that's a high risk person. That person I charge ahead and do lots of tests on. But if I do a risk stratification, either my Gestalt or I'll tell you some of the measurements in a second, so tools, and I walk out saying, well, it's not no likelihood. I can't say this is just their asthma because this one thing is just too different than their usual asthma exacerbations. I don't think it's highly likely here. I don't even really think it's intermediately likely, but it's definitely on my radar. That is the person where I'm going to think about using a D-dimer. No risk at all, don't do anything. If they're low likelihood or higher, then I'm going to go into an algorithmic approach. And to figure out that likelihood, that risk stratification, the data, by the way, out there, when they've looked at physician decision-making, physicians, and they haven't tested yet all clinicians, so I can only speak to what's been published. Physician decision-making, their Gestalt, when they walk out of a room, turns out to be about as good as these scoring systems I'm going to talk about right now. I like to use them as a hybrid. So I like to use a scoring system so I can document it on my chart, but I let kind of go in there and trumpet if that's what I need to do. It's like, the scoring system's not so worried, but I'm more worried. I use that. So let me show you how this works. So for instance, Wells criteria is what most people use. There are lots of different ones out there, but this one's super easy to use in the emergency department. So Wells risk prediction score. This is a likely, unlikely kind of deal here. And the reason I use my clinical judgment is look at the clinical features on here. So look at these clinical features. So if I have somebody as a DVT, I'm very comfortable with that physical finding. If I have somebody with a heart rate of 105, it's 105. That one's easy. That's a black and white thing. If I have somebody who said, oh yeah, I had a clot in my lungs before, that's a done deal. If they're coughing up blood, if they have cancer, those are easy. Those are kind of like off-on switches. They're yes-no deals. What isn't in here, though, is the second thing on this list. It is basically other diagnosis less likely than PE. Now, first of all, that's just so weird to get your head around, right? That's a crazy thing to get your head around. What this says is, let's go back to that asthma patient. That asthma patient, boy, it sounds like asthma, it smells like asthma. That other diagnosis, that asthma diagnosis, that's not less likely than PE. It's what it is. But boy, it sounds like asthma, but I can't say for sure it's really what's going on here. It's not. So I'm really worried that PE might be in there. That other diagnosis isn't necessarily less likely than PE. PE might be in there. That's where that comes in. And that decision's hard. And that's where a lot of us don't agree. And that's where this scoring system falls apart. So it's fine to say the score ends up being, 2, but that heart rate is at 99, and it's just one short of 100, and that person's not comfortable. So I'm going to kick in another 1.5 here. I'm going to let my Gestalt say, I'm still worried enough to continue my workup. So my recommendation is know how these things work. Well, this is the Wells. Go ahead and document it in your charting, but use your head. And go ahead and say, a Wells score only X, but I'm concerned because patient has, is a little more tachycardic than seems appropriate for their condition, I'm going to continue my workup. Boom. If somebody comes out when you do that, though, as a low risk, so yeah, sure, the only thing that's different from their other asthma, they're not tachycardic, they haven't had a DVT, none of this other stuff, they're in this low risk group, you can apply what's called the Perk Rule to. Now, what the Perk Rule is, do use your MD calc. You're going to basically say, okay, I walk out of the room, I think it's a low-risk person. Their score came out that way, my Gestalt feels the same way. Yeah, it's probably 10% risk, 15 maybe on my phone. And I'm going to go through all 8 criteria of my Perk Rule. And if they are negative on all 8, that means is I can stop now ordering no tests, zip, nothing. I don't order a D-dimer, I order nothing. What that score does for me is it decreases the risk of a symptomatic significant PE within the next, I think, 60 days or 45 days, within a next short amount of time, but a decent amount of time, down to less than 2%. So I'm not working up a lot of people for nothing. These people tend to do just fine. This is the algorithm, and it's actually not complicated at all. I go to my little green box. It's a suspected PE. I go ahead and figure out my risk stratification tool here. If they fall into that middle area, it's kind of a low-ish risk. I'm going to first do my Perk Rule. If my Perk Rule, it's sitting out here, basically says it's Perk negative, so I go to my Perk Rule. Let me see if I can get this thing to work. Is that working? I was told this thing, oh, there we go. So there I am, I'm over here. I basically low likelihood over here. I go down and I do my Perk score. If my Perk score is negative, I'm done. It's like all 8, not happening. I say, you're good to go, no more tests. However, if they fail the Perk rule, and any one of those doesn't fit, they fail it, or if they're just low risk ahead of time, and I'm not going to I can't perk them out, I'm going to go ahead and do a D-dimer then. That's the only time. You'll notice that's the only place to put the D-dimer. It's not over in the people that are super sick. It's in that tweener zone where they didn't fit Perk, but I still need to move. I'm done again. So I'm done twice. I can be done early twice. One is by perking some. If somebody's super high risk, I walk out and it's like, wow, that sure sounds like a PE. I'm not going to touch the dimer at all. I'm going to go right to imaging. And most of the imaging we do is CT. This algorithm, you can reproduce every single time. Because even with some, okay, but you're not if you do this appropriately. So this algorithm I highly recommend you stick to. It's going to keep you from ordering too many tests. It's going to keep you as accurate as possible. And if you do miss something, it won't be something that's usually a terrible PE at all. Now, imaging itself, the whole debate about VQ versus CT scanning to me is a specious argument. Who can get a VQ scan in? Everybody radiated, so only do the ones that are appropriate. But CT is what most of us do. A CTPA is what most of us do to rule out PE. Here are some images just for fun. The reality is CT is what most of us do. Now, if somebody's take them out, we know that your heart rate goes up as part of your normal hormonal response to pregnancy. So women may end up with a resting tachycardia just being pregnant for part of their pregnancy. The shortness of breath. What pregnant woman near term isn't short of breath? You've got, junior basically shoving your lungs up into your throat. You have no way to breathe anymore. So the things that we think about when we see a woman who's pregnant on how to figure out what to do with a woman who might have a PE in pregnancy. So you really need to keep, and it tends to be a little worse later in pregnancy, but see if they've updated it. They haven't. They flat out say, do not use a D-dimer in pregnancy. Don't. We know it goes up in pregnancy. We know it's kind of erratic in pregnancy. Don't use it. Are they truly predictive of a low risk? And it turns out they may very well be, but right now, according to ACOG, they don't want you using it. They basically say if somebody has leg symptoms and they're pregnant, go there first and image the legs. And they actually recommend imaging both legs. That's fine. If they're positive, okay, we've got a clot, at least in the legs, we're just going to go ahead and treat anyway. If they're negative, then, quote, more testing is indicated. And this is where you have to make a decision. And honestly, we have to go to the lungs to see. If I'm worried about it, I have to go to the lungs to see, but I would prefer not to radiate. So CTPA is still what most people do. It radiates mom more than baby as long as things are protected. But it turns out that MRPA, if you have an MRI scanner, that may be a way to do this. Also fresh stuff, not well-studied stuff, but know that it's an alternative as far as working up a woman who's pregnant who might have a PE. So this is sort of the recommendation here. They recommend, this is the recommendation. This is their algorithm, and it's based, and this is a study that's trying to look at are there clinical criteria in a pregnant woman and D-dimer cutoffs in a pregnant woman by trimester that we can use to safely study. It was pretty good, actually, at helping you figure out low-risk people and when you can say I'm done and how you rule it in, etc. It hasn't been well duplicated yet. I have this in there for you so that you know that there are people looking into this as alternatives. Treating PEs, heparin, a little different, but again, if you have a pregnant woman who has a PE, you're talking to her OBGYN on the phone from the get-go anyway. You can use novel anticoagulants in non-pregnant women for outpatient therapy. We'll talk about that in a sec. And breaking up the clot, fibrinolytic treatment, TPA or some sort of lytic, can't get them out of shock. They have this ginormous saddle embolism. I need to get that thing gone. We have a PE team, basically it's like a stroke team for PE at our institution to help kind of sort this out, because there are alternatives on things you can do in these cases that are so profound to lytics. But if you're in the middle of nowhere and you really are highly suspicious, it helps if you have an ultrasound, but if you don't, whatever, you're looking for right heart strain, it's good to go. Go ahead. If they're dying of this thing or just died of this thing, go ahead and lyse them. Most patients are admitted, but you can send some patients home. Now, I'll tell you, anybody who works in the Kaiser system in the States or anybody who's from Canada, you're used to sending people home with PE. We know some people can go home with PE. Our job in those cases is to make sure it's safe. Okay, we have novel or anticoagulants we can put people on. I can give you a pill right now. You're anticoagulated within hours. That predictably so. Low risk for something bad happening when you send them home. I'll tell you, not a lot of people qualify. If you really go through it step by step by step, a lot of sort of hoops have to be jumped through. You have to have drugs available to them, their meds, follow-up, etc. But know that some people can. I'm going to end with DVT. So DVT is just common, super, super common. People get this all the time. It's the same risk factors. It just happens to be in the leg only in these cases. And you basically, oh, by the way, it looks often like this. And I do want to mention 2 conditions that can happen with DVT that are true right now. I need a surgeon come in and operate, like Measles cerulean alba. What they are venous clots, usually proximal, that are so big that I am causing vascular embarrassment to that leg, either arterial or venous. Where it usually starts venous, I get a big engorged leg that tends to turn kind of whitish, bluish, and then eventually I end up with this big purple leg. It is exquisitely painful because it's ischemic. You will not miss this. You're gonna walk out of the room and say, gosh, that looks like a DVT, but wow. If you do that, if you walk out saying, oh, get on the phone. That's a leg that's at risk. It's a dying leg. It's basically an ischemic leg. The diagnostic criteria for DVT are very similar in concept. There are risk stratification skills here, of algorithms here to kind of figure out who's who, and imaging is basically usually ultrasound. So here, by the way, is one of the criteria things for high risk, low risk. And here's what some of the imaging looks like. So here's what ultrasounds can look like. By the way, some of us do our own ultrasounds for DVT. We are trained in our ER to do it with our ultrasound. Most people aren't, though, out in the real world, so order the test if you feel you need it. Again, I mentioned novel anticoagulants, fabulous way to treat these. So a lot of people who have DVTs go home on these from the get-go. I will tell you one, if they have bad renal disease, you shouldn't be using these. Make sure they're not pregnant. Make sure that they don't have any other risk factors for bleeding, that they can get a hold of the medicines. Sometimes they can't even get the medicines themselves. Make sure there's a way for them to get the meds themselves, that they actually are covered on their insurance, they can actually get the meds. So that's the embolism thing. Use the algorithm, please. Use the algorithm because it will save your soul when you miss the ones that you will miss, and it will also help you do the right thing from the get-go. Thanks a lot. We're going to do Q&A. Thanks.
Okay, cheers.
I am thirsty, thirsty, thirsty.
Hello.
Okay.
Take a sip of water. I'm thirsty.
Sorry, sneaking behind you.
Cheers.
All right, this is our last section for today. You guys made it through the first day. Are you so excited? You did it. You did it.
You learned
did
so
it.
much stuff, right? There's all this stuff you learn.
The idea now is to go home, back to your room and study the manual for tomorrow.
Take it with you to the craps table. That'll get their attention.
Go out there and start identifying all the rashes that you know what they are. You know which ones they are.
Walk around through the casino.
Don't touch it if you don't know what
That's
it
right.
is.
Don't touch it if you don't know what it is.
Did you know that the Archives of Dermatology, the journal, used to be called the Archives of Dermatology and Syphilology? It was called that until the 1960s because syphilis causes so many rashy things. So yeah.
Syphilis. Who wouldn't want to? Okay.
Take it away, Martha.
Let's start with this
Anytime you're ready.
first one. Okay, I like this one because do you have any recommendations for new ED clinicians for classes geared towards lecturing how to read, learning to read x-rays? Rick, you want to tell them?
Where could they possibly get that information?
Well, we have what we call an advanced food camp. Not that it's basically, it's advanced. And we have a 4-hour radiology imaging section, and we have a 4-hour EKG section that precedes the main course. So there are these 2 mini courses that would get you a jump start in terms of radiology for the emergency department or the urgent care center that is simple x-rays. It's not really based on CTs because you're not going to be reading the CTs. That's for a doctor in India to be reading. That's where they read that stuff. But for
12th is that course.
Oh, but thank you. The actual repairs.
Across the driveway. Next question.
Okay, next question. Is there a quick reference app you can recommend other than the Sanford guide for which pathogens each antibiotic covers? Why, yes, actually. I have one for that. EMRA guide is great. I actually have a copy.
EMRA.
Yes.
EMRA.
I have a copy of it over there on my table, but you can also download that for your phone. Okay, so that's a really great one.
It's good because it's emergency medicine
Yeah.
geared. A lot of like even Sanford, right? It's not emergency medicine focused. It's ID focused, really.
Right.
So it really boils it down to what you really want to know. So I think
love
it's
it.
just very,
I
very
go to Sanford if I
practical.
want the nerdy stuff, and
Yeah.
I go to EMRA if I want the just tell me what to do.
Yeah.
Right.
Yeah.
Yeah, and at least at my hospital, again, remember that recommended antibiotics for certain common types of infections based on your formulary, your resistance patterns. That we have that where I work, and I use that more than anything else in terms of choosing.
Section.
Depends on your place.
Yeah.
I mean, E. coli in one place may respond to something very different than E. coli somewhere else.
Yeah, and MRSA has different resistance patterns now, so all of that's relevant.
Okay, any aftercare instructions to give a diabetic that would benefit from steroids, like, for example, daily metformin or dietary changes, or defer to primary care for close follow-up? Would you reduce the dose of the steroids, et cetera?
So my feeling on this is, one, if the steroids are indicated at a specific dose, use the dose. Okay, if you really think you need to use this, or their sugars. The good news is it doesn't usually, putting somebody on steroids doesn't usually throw someone into DKA. But it may get their sugars out of whack, the things that are usually sort of on balance, it can get them out of whack. And if they're good at following their sugars and their sugars are out of whack, they can call their endocrinologist or their primary scale to use. I am not about to prescribe that from the emergency department at all. And they can always come back if they feel worse. So.
I think the question about diabetics and steroids is an interesting one because in each scenario you have to kind of think about how indicated are the steroids.
Right.
Is this something where it's sort of marginal or, like the case, let's say it's pharyngitis and Dex, do I really need it? Do I not need it? How brittle is the diabetic? How out of control might they be? We have to do that risk-benefit equation, I think, for patients. And we're not great at educating patients about side effects of steroids.
Right.
Steroids have a lot of side effects. They can make you not sleep. They can make you feel crazy. They can
Yeah.
do...
Jan, so don't give it to me.
That's actually really true.
Yeah.
If you've ever had a friend or you yourself have been put on steroids, I'm cleaning my closet. It's like, what are you doing?
Yeah.
It's like, well, I went to the doctor today. Oh, you got your steroids.
Yeah.
That's what's going on.
Yeah, at our hospital, we had a desperate in terms of a back injury because steroids don't work in back injuries.
Right.
But sometimes you get desperate and you look around and say, I'm going to try it. And so I've seen a bunch of people on the week, or the 1 week, we never necessarily see to come together and say, listen, let's get this straight.
Yeah.
Let's, something's going on. You've come to the emergency department. Let's do some shared decision making and let's kind of talk this through. Nobody's going to force anybody to get any test here.
Yeah, and lying about why you're doing it is
not good.
unethical. So,
Well, yeah, this is an ethical question more than a medical
Yeah.
question, honestly. And most ethicists will fall on the side of you can't do that, period. Patient autonomy counts even for kids, that you can't go behind their back and get something because a parent wants it.
And if she's pregnant, she's not under the parent's control anyway.
yeah, it's a bad idea.
Okay. The next question is about ondansetron, Zofran. And this question, they first asked, do you send peds home with a Zofran script or just a single dose in the ER? But they went on to ask the following, some questions about a head injury. So that's a tricky one.
Head injury, who's
you
vomiting?
have a head injury, is it okay to send the patient home with Zofran?
And a negative head CT?
Yes.
Yeah. Assuming that there's a negative head CT.
And I'm assuming we're talking kids, or is this just
Peds.
everybody?
Yeah.
Okay.
Only
No, that's fine.
peds.
Yeah. If you had a negative head CT, because you, of course, obviously with vomiting, you'd worry about, in the setting of head injury, a real
Right.
head injury. I would never send someone home symptomatically without knowing for sure there's nothing going on. But people with post-concussive syndrome, could have some nausea, in which case symptom control is reasonable.
Yeah.
Yeah. Plus, it's great for the parents to keep
What was
around
the
for
other
when
part
they're
of that question,
hungover.
though? That comes up a lot. Can we do something with this drug? And it tends not to make a big difference, to tell you the truth. It's not like a miraculous kind of improvement that they get. So you don't expect a lot. You can say, here, let's give it a try. I feel comfortable with the diagnosis, and that's another thing. It's a lot more easy to know the CAT scan is negative than to know what's exactly going on. I like the idea of, remember, symptoms, if the symptoms get worse, new symptoms develop, they come back to the emergency department. And so I'm not, unless I feel really comfortable, literature says it doesn't really make a difference in terms of the return rate to the emergency department.
Okay. Next question. Have you heard of early pregnancy patients refuse pelvic ultrasound due to possible risk of friction from sound waves causing harm to fetus?
So there were some publications back, but when we were doing Doppler more than M-mode findings in children where they found that there were some reverberations. This is the friction I'm assuming that they're talking about. M-mode doesn't do it. So most people, especially if you're doing heart.
I've never personally had someone refuse it, but I believe that it happens, just not, I guess, in my patient population. It's not something that I've come across, but I would just have a discussion about what, the ultrasound can add in terms of benefits for the whole situation and diagnosing what's going on, giving information that I have no other way of knowing. Hopefully you can kind of talk someone down from that fear.
So Mike Sharma, who's going to be here tomorrow, was answering some of your questions, and he said,
When Mike gets up here to speak.
Okay.
already pumped up.
Is he here, really?
Okay, let's go on to the next
Next
one.
question.
Please move on. That's otherwise going to have that in my head the whole night.
Is PID etiology always an STI, Jan?
No.
This is a good one, and I actually spent a little time looking this up, but is exogenous testosterone a PE risk factor?
What did you find?
Well, I found a lot of articles, Diane. I mean,
But
there,
did you find anything definitive? There's lots of
No.
That's so.
No.
I haven't seen anything about that.
but I also read that is there really any great benefit of using testosterone in general, which I thought was interesting, took me down a whole
A
nother
lot
road.
of people making lots of money.
So-
Yeah.
Oh, they sure are.
Yeah.
Why didn't I go into that business? So yeah, if you do your own literature search, and I posted a couple of the things that I read, it's very interesting, I will say.
An association, so be careful with the word association.
Yeah.
Association just means people with gray hair have an increased death rate. It doesn't mean that if you're 27 years old, them don't necessarily, there's no causation there. It's an association. People who drink beer die of lung cancer because people who drink beer tend to.
Here, I wouldn't be buying any green bananas.
I would be
Oh,
7
okay.
years old.
Banana-
Thank you.
Okay,
Yeah,
okay.
I appreciate that.
All right, let's